Hi, Chris. Is it okay for you to be televised even after finishing live? So that it is. Thank you. Hello, everyone. It is time for us to go. So that it is great pleasure to have this the Thursday forum from the Preventive Medicine Association of Korea. Today we will have Professor Chris Bullen from the New Zealand, the University of Auckland. Before starting his lecture, let us introduce our global purpose of our Thursday forum of our association. Let me invite Professor Hong, the coming president of this association, to introduce the purpose of the forum today. He might be saying in Korean. Thank you, Professor Hong.
안녕하십니까. 저희 예방의학회 기획위원회에서 앞으로 시리즈로 목요포럼을 기획하게 됐습니다. 사실 제가 예방의학회 이메일을 통해서 이제 공지를 드렸는데, 저희가 오타와에서 평창까지라고 하는 이제 새로운 슬로건을 이제 하나 이제 만들었습니다. 그거는 우리가 오타 헌장, 사실 우리 예방의학회에서 또 퍼블릭 헬스에서 굉장히 중요한 헌장이었고, 그것이 이제 건강에 대한 신체적, 정신적, 사회적 건강을 어떻게 담을 것이냐, 이제 사회의 구조 속에서 그래서 이 사회적 결정인자라고 하는 개념도 만들어지고 상당히 중요한 헌장이었습니다만, 당시의 기후변화라든지 또는 인구 구조의 급격한 변화라든지 또 더욱이 신종 감염병의 출현 같은 것들은 사실은 충분히 담지 못했던 부분이 있어서 이제 우리가 그 다음 단계의 예방의학적인 의제를 만들어가고 또 그것을 어떻게 해결할 것인가가 이제 진지하게 고민해야 되는 때가 됐다. 저는 이렇게 생각합니다. 그래서 이제 그런 논의 틀을 뭐 한 번에 만들기는 어렵기 때문에 우리가 가능하면 여러 연자들을 통해서 또 다양한 주제를 통해서 새로운 예방의학의 길, 어떻게 보면 새로운 의학의 길, 또는 어떻게 보면 새로운 사회 발전의 길을 좀 모색해 가야 되지 않겠나 하는 그런 생각에서 기획위원회에서 이렇게 계획을 했습니다. 오늘은 외국인 연자 크리스 블렌을 모시고 하지만 외국인만 모시는 것이 아니라 다음번에 이제 국내 연자 모시고 또 이렇게 진행을 하고 가능하면 다양한 의견들을 좀 모으는 그런 포럼으로 발전시켜 가고 싶습니다. 그래서 뭐 좋은 의견이 있으면 언제라도 저한테 주시고 현재는 기획위원회에서 하고 있고 이제 앞으로도 기획위원회 주관으로 하겠습니다. 그리고 또 제가 또 내년부터는 또 차기 이사장이기 때문에 이런 부분들을 조금 더 무게를 두고 좀 진행해 가고자 그렇게 합니다. 그래서 많이 참여해 주시고 또 같이 만들어 가 주셨으면 하는 그런 바람입니다. 무엇보다 오늘 또 첫 테이프를 끊어주신 크리스 블렌 박사에게 또 감사를 드립니다. Dr. Chris Bullen, I really want to express to you about my thanks. So you are the first speaker of the very important series of the lecture, which is the drawing of the future map of the not just preventive medicine but also medicine in general or the society in general. So thank you very much again for joining and your speech.
Thank you. Professor Pullen will give us a lecture with titled Digital Innovation for Population Health Improvement in the 21st Century. Let me briefly introduce Professor Pullen's bio. Professor Pullen is a professor of public health at the University of Auckland, New Zealand, where he leads a team of academics at the National Institute for Health Innovation. His research interests are broad, but he's most well known for his innovative work in tobacco control research, with more than 180 publications in this area alone. He also has particular interest in the use of digital and mobile technologies to reach people where they are and support them in their health. Professor Pullen has a career-long commitment to global health equity, working as a doctor in the developing nations for almost a decade. Then as an academic, mentoring and supervising students and emerging researchers from around the Asia-Pacific regions. Today, from on behalf of our audience, let me thank for your participation as a lecturer today. Professor Pullen, it's over to you.
Thank you so much. Thank you very much. And thank you, Professor Hong and Professor O, for your warm welcome. It's a real privilege and a great honor to be able to talk to you all today. I'm coming from a very warm Auckland, where it's just the start of our summer. So I'm sure you probably welcome a change of climate at the moment. So if I have the occasional glass of water, it's because it's really quite warm in my office where I'm talking from. So as has been noted, I work at the University of Auckland. Auckland is a city of about 1.5 million people. So it's small by Asian standards, but it's a very ethnically diverse city. And you may be surprised to know there's actually quite a large group of Korean people living in our city who make a wonderful contribution to the life of our community. The group that I lead has been a centre at the University of Auckland now for over 30 years, and it has changed from being a clinical trials centre to one focusing on innovative approaches to population health improvement. And that includes a large focus on using readily available digital tools to try and address some of the biggest public health problems that we face. So I have teams of wonderful colleagues I have the privilege of working with who are focused on nutrition, physical activity. I'm involved in a group particularly focused on addictions, including tobacco and alcohol and gambling. And then we have other work in youth mental health and then a whole digital team of developers working on apps and messaging and interactive operability tools. So it's a great area to be in because I'm always learning, and I guess that's one of the things that, you know, in public health, if we don't continue to adapt to the changing context, then we run the risk of becoming irrelevant. So what I want to talk about is this whole idea of digital innovation, how that relates to population or public health, the idea of digital public health, and draw on some examples from my own work as well as work of other colleagues, but also look at the use of digital tools in the COVID-19 response, where I think we are really pushing the margins out and learning some new things about how these tools may provide opportunities, but also some concerns that we need to take on board. And then to finish with some thoughts about what next, where to from here, with this idea of population health improvement in the third decade of the 21st century and the use of these kind of tools. I guess, you know, for those of us who've been around a long time and have a few grey hairs or not too much hair left, you know, there's been a huge transformation in the world during our lifetimes. And we're now in what's been referred to as globalization 4.0 and the Industrial Revolution 4.0. This is the World Economic Forum several years ago coined these terms. And then they came up with this idea of Health 4.0, which is the digital transformation of health and medical care, both in its practice and governance. And really it raises almost hitherto unimagined possibilities for predicting health outcomes, for prevention, and for treatment. To the extent that people are now talking about, precision health, using biomarkers to intercept diseases before they even become symptomatic, and to be able to highly target them with interventions. And what seemed like a futuristic dream, even just a decade ago, is now almost every day at our fingertips. When I was a boy growing up, this was what a telephone looked like. And I remember my first computer that I bought a couple of decades ago was sort of something like this, very heavy and large, very slow, with very limited capacity. And then, in the last few decades, we've had the internet and the opening up of the possibility of tapping into knowledge from all around the world, anytime, anywhere. And this Zoom call is itself a reflection of the extremely fast-paced movement of information technology that enables me to talk to you now from the comfort of my home in Auckland to you in Korea, and without having to hop into a plane and fly for 10 hours. It's remarkable. And it's now quite an everyday occurrence to use our mobile phones to access information, for robots to be used in healthcare and disability care, for telemedicine to be very, very commonplace, and even for virtual reality to be used as an evidence-based tool in many situations. And again, these are things that we could have only dreamed of not that many decades ago. I want to talk a bit about mobile phones because I think this is where one of the greatest opportunities lies for public health. There are now more than 7.5 billion mobile subscriptions, so that's billions more really than subscribers, for almost the same number of people on the planet. People, in fact, have better access to mobile phones than they do to clean water and toothbrushes, which is a remarkable statistic. And the growth of mobile networks covering much of the globe is now phenomenal. So if you look at this figure from the International Telecommunications Union, the ITU, which tracks these sort of things, this is from a couple of years ago now, so it's a little historic because it's so fast moving, but you can see the trajectory that the level of internet use is outstripping the growth in the world's population, and third generation or fourth generation broadband access is now growing very, very quickly and outstripping even basic internet access. So while 93% of the world's population lives within reach of a mobile broadband or internet service, however, there is a gap and only just over half use the internet. But nevertheless, it is remarkable that in the space of under a decade, most of the world's population can access the internet through mobile services. And in terms of subscriptions and cellular subscriptions, you can see the growth here. Year on year, almost 20% growth. That's that green line, and that's active mobile broadband subscriptions. So fixed line telephone subscriptions are dying out, and fixed broadband wire subscriptions are also dying out or growing very, very slowly, but essentially flatlining, whereas mobile cellular subscriptions are continuing to grow at a huge pace, and particularly active mobile broadband subscriptions. So this means that almost everybody on the planet, potentially in the next 5 to 10 years, will have access to the internet through an affordable handset. Now, Sir Donald Acheson, who coined this definition of public health in the 1980s, could probably never have imagined that this would be the case. And Atchison defined public health as the science and art of preventing disease, prolonging life, and promoting health through the organized efforts of society. And I wonder if he ever imagined that the organized efforts of society could conceivably take place in the way that we're having this discussion, this conversation now over the internet. That people could get together around the globe and come to agreement on many things and work together in collaborative ways that were hitherto unimagined even just 10 or 20 years ago. So we're still interested, I'm sure all of us, in preventing disease and prolonging life and promoting health, which are the building blocks of public health. But perhaps the way we do it in the 21st century, or at this point in the 21st century, needs to be reimagined and re-envisioned. The Ottawa Charter I always look to as a wonderful way of thinking about the key strategies that we use in public health. I think it was very far-sighted. And it imagined, settings as being important for doing public health work. But I wonder if and I'll come back to this later, thought about virtual settings in the way when we think about, creating supportive environments and developing personal skills and strengthening community action. And then how do we tackle the determinants of health using digital tools? This is a challenge, I believe, for the digital health movement, if you like, is to keep forcing our gaze outward at the rainbow model here that was proposed in the 1990s by Dahlgren and Whitehead, where the general socioeconomic, cultural, and environmental conditions, which we know as public health people, have the greatest impact on the life trajectories of people. How do we address those underlying determinants of health and not just focus in on individual behaviors when we have such individually powerful tools at our disposal? So these are some of the things I want to talk about with you. Data and public health, of course, have always had a very close and long relationship. This is John Snow, who tackled the Broad Street outbreak of cholera in London in the 1800s by removing the pump handle. But he did that after he had analyzed data on the outcome of disease and using disease mapping. Today, of course, we have more sophisticated mapping tools and disease tools and modeling and so forth at our disposal as a result of the technological revolution. But this relationship between data and health has a long-standing history. But now we can talk about digital public health and the idea that Chris Murray and colleagues have proposed in an article written in Lancet Digital Health in 2020, defining digital public health as the use of technology, new types of data, and new ways of working that come with the digitization of public health and associated data. And we'll have a look at some examples of that. But here are some thoughts around what that might look like. We have new ways to collect data through efficient administrative interfaces and sensors and non-traditional sources of data, such as social media. We'll look at some examples in the COVID response of that. New ways to link those different data sources together to develop new insights into disease occurrence and its causation and how to tackle it with interventions. New ways to visualize and analyze the data. And then the ability of a diverse range of organizations, governmental and non-governmental, including citizens, to work with that data in order to be more effective in communicating both with the public and with decision makers about what the insights are. The World Health Organization has actually been promoting digital health for some time, and this is some information from their Be Healthy, Be Mobile site. I'm not sure if you're aware of this, but they've been looking at the opportunities there are with mobile health, using mobile connections to communicate with people to save lives and improve the world's health through digital channels. And it was created as early as 2012, which seems like a very long time ago, to address challenges, particularly for low and middle income countries, where the reach of mobile was showing promise. And so my group at the National Institute for Health Innovation have pivoted from doing if you like, analog clinical trials to test the effectiveness of interventions to focusing much more on digital solutions and testing them using those same epidemiological tools for measuring effectiveness and cost effectiveness and equity, but in the digital space. So even though we've been locked down in Auckland for the last 4 months and now coming out of that, we've been able to continue most of our work because it's all been done remotely. One of our early pieces of work was with smoking cessation. Over 15 years ago, we published a paper in Tobacco Control Journal, BMJ Journal, about a small trial we did in New Zealand using text messaging for smoking cessation. I found it almost doubled quit rates among people who took part in the program. We scaled that up in a partnership with the London School of Hygiene and Tropical Medicine, 9,800 people in a randomized double-blind controlled trial, 12 months outcome measures, verified by biological measures for smoking cessation, found exactly the same. That was published in The Lancet. So quitting smoking through simple messaging without pharmacological interventions has been proven time and again in a range of settings and scenarios to be highly effective at helping people to quit smoking. It's incredibly cheap. It can be fully automated. It can be tailored to individuals. And it's a great model for thinking about how we tackle chronic disease, risk factors, and other issues. And I'm just going to show you some of the other work we've been doing in this space. So we adopted recently the cessation messaging model and built it in a mini program in WeChat in China. This is my PhD student, Jin Song Chen, who's now graduated with his PhD based on his groundbreaking work. And just we did a pilot trial in China with WeChat. And in a 13-day recruitment period, we had almost 6,000 visitors to the mini program. And we showed evidence of high acceptability and smoking cessation benefit at almost a no cost, apart from some of Jimmy's programming time. So this is the way we can deliver to people who can't access physical support remotely. We could actually verify in the research environment. We were able to deliver smoking cessation testing kits to these people using Alibaba. Within 24 hours, they had a saliva testing kit, and we were able to get them to take images of the result, upload them to our website, and verify the result of that test. We've just published some work with some colleagues at another university here in New Zealand looking at the effect of smoking on people's voice as a way of bio-verifying whether people are still smoking or not. And that's using artificial intelligence machine learning tools to test people's voice change before and after quitting smoking. And that can be done remotely. Other areas that we've been testing have been to adapt work done in other constituencies, just to do simple messaging for supporting young mothers with their children. And we've tested that in 16 different versions in our city with different cultures and languages and relationships to their baby to provide them with support around infant nutrition, weaning, and immunization support in a program called Text Match, which was adapted from an NIH-funded model in the US. And this is the kind of back-end work that you need to do in order to take the core concepts and run them through a series of focus groups with the end users and co-design the messaging and adapt it culturally and linguistically through a series of processes before you can roll it out. And you'll be interested to see some of the languages we used here include Korean there on the, and this is just some examples of the messaging we had for mothers using this program in Auckland, New Zealand. And some of the kind of levels of work that you have to back end behind your product just for simple text messaging. And this is not an app, this is just SMS messaging, but highly effective when tested in a randomized controlled trial. I have a colleague working with young Indigenous Maori New Zealanders at the moment on a program called Text Pepe, which just means text for baby. Same approach, different population group. Cultural adaptation, linguistic adaptation, really important. And her work was built around a messaging program for diabetes self-management, published in a 2-arm parallel randomized controlled trial in the British Medical Journal. It's also PhD work. And again, the back end of making sure it's clinically safe, as well as highly acceptable and engaging, requires a sort of a mix of psychology and marketing, clinical medicine and public health, as well as IT savvy to put all this together. So it's a very multidisciplinary work with end users at the core, all the way through very much a co-design project. And this is the infographic that was published in the BMJ with the paper. And we saw a reduction in HbA1c in the intervention group that was statistically greater and clinically important compared with the control population in this RCT. Taking the co-design to another level, we spent a whole year with Maori and Pacific people in an app that was built around their individual models of health. So for Polynesian peoples, their idea of health is very broad compared to, say, a Western model, which is built around mainly physical health with a little bit of mental health coming into it. The Polynesian models incorporate spirituality and models of family, extended family. So to be a healthy individual, you also have to have healthy relationships. You have to have a relationship with your spiritual, your God, as well as your family in order to feel healthy. So we had to build in these concepts. And this took a year to co-design with population groups and develop the right kind of iconography and symbology into the apps to make them highly acceptable and effective. We've just finished another randomized controlled trial that's used mobile phone imaging, taking nutrition labels on commonly available supermarket foods, as well as Bluetoothing blood pressure machinery, linking that in with urine salt levels to measure the outcomes of a salt or substitution trial called the SALT study. And you can look at it on the trial registration there. And then we've done some work on mobile pulmonary rehabilitation for people with chronic obstructive pulmonary disease. We're developing an app at the moment with all these partners. You can see along the bottom of the slide, which includes pulmonary exercises, action plans, a model of the lung, family support, relaxation tips, and questionnaires, and so on and so forth. There are many dimensions to it, but also incorporates feedback from end users that help us to continue to improve this app. Then we've moved into the area of youth mental health, and this is the Sparks immersive gaming tool, which uses cognitive behavioral therapy for young people to deal with mild to moderate depression. And this has now been rolled out by our Ministry of Health in New Zealand as a game that New Zealanders can download. Unfortunately, you can't download it off the Apple or Android store in Korea. You have to get some sort of a license to do that. But this is proven in a randomized controlled trial to be effective at reducing mild to moderate depression in young people. And so it's been rolled out for a number of years now. And we've had fantastic outcomes from our real world data of measurable decreases in mental health measures from our young people here in New Zealand playing this game, enjoying playing the game, but while they're doing it, they're getting cognitive behavioral therapy. Developing all these tools is one thing, but getting them implemented in the real world, from the research to support and commercialization or Ministry of Health funding, is really, really quite challenging. And this is, we've found to be quite a struggle. Unless there's deep involvement from our end users or supporters from early on, it's very hard to get ongoing funding beyond the life of a research project. We've also struggled with the hype there is sometimes about technology access and found it not always to be as good as was promised. Digital literacy amongst users and clinicians is obviously sometimes not as good as people might suggest. Having to keep the content up and relevant and culturally appropriate is a challenge. So just having a one product that cannot be changed is a real issue. It needs to be updated. And so there's also the risk of actually suddenly creating a groundswell of demand that wasn't expected on healthcare providers as a result of unmet need that is now tapped into through these tools. You need to have ongoing back-end technical support, and you need to make sure that the right people are receiving this product, and you're not just widening the gap between the haves and the have-nots. And the other thing is the digital space is becoming increasingly crowded. However, it's not always evidence-based. And so it's really important to think about the kind of tools that we use being underpinned by evidence. I want to talk about some of the great initiatives that we've identified as a result of the terrible pandemic that we've all been facing around the globe. And some of these next few slides draw on an excellent paper that was published in Nature Medicine last year by Budd and colleagues, which talks about the different types of technologies that have been used in the COVID-19 pandemic. And I think, you know, we've all got used to using many of them ourselves in our daily lives or tapping into them in our work. This picture on the slide shows our Director General of Health referring to the QR code for scanning when entering premises that we all have become used to. And the screenshot of the mobile phone is a chatbot that's there to provide mental health support for people who are in lockdown. And then the image, the graph on the right-hand side shows the information from our World in Data, which is a wonderful amalgamation of global data on what's happening with COVID-19. None of these things would have been possible or even imagined that we would use in our daily lives to get through this situation. And these are some examples of the tools. But on the table, we can see there have been tools built around digital epidemiological surveillance, and then using machine learning to analyze and make sense of and use predictive tools from the data that's collected. We've been able to identify cases rapidly through wearables that predict when somebody might be developing, you know, through a tachycardia or pyrexia developing early. Sensors can develop sense that earlier than the person can detect their own symptoms. And that can be put through various algorithms and flash alerts. We've been able to use smartphone app and Bluetooth technology to do digital contact tracing and therefore shut down the transmission of COVID-19 and community outbreaks. We've been able to get through to people around our countries using social media platforms with targeted communications and provide them with support like this chatbot here, and then engage in the kind of conversations that we're having right now through tools like Zoom, Teams, and other platforms for teleconferencing and telemedicine and sharing information. Excuse me, I'm just going to, someone's trying to get me on my mobile phone. And then these things have been all put together, and this slide just shows some of those interconnections of digital technologies to enable the tools to be used to their maximum potential. You can see the use of mobility pattern analysis, and we'll show a slide that Professor O was involved in leading some work on this. But this image is just of a wearable app, wearable Fitbit type of device that picks up heart rate and temperature, feeds that into this app called Elarm, which has been used, developed in New Zealand by a local IT company, but it's been used all around the globe now. And it picks up early on a change in your heart rate and temperature, feeds that through an algorithm, and can predict someone developing a febrile illness within 3 days. And so it could actually alert people to the possibility of having an infectious disease and going and getting a swab done and self-isolating until the result comes back, and thereby preventing potentially spread in the community. This slide is also taken from that Nature Medicine article, and I like it because it shows the public at the top of this hierarchy of collective data gathering and the tools that are needed to preserve privacy, the use of digital data sourced from citizens sometimes, as well as passively sucked out of readily available tools like social media, providing information about, sending recommendations about the need to isolate, visualizing that data in ways that can be understandable and rapidly taken up by citizens and by decision makers, enabling communication with healthcare providers. And And I'm just going to highlight a couple of examples of how I think it's important that we manage communication well. Digital public communication is a two-way street of feeding information to the public, but also trying to immunize our public from misinformation and disinformation, which is a huge problem, particularly around vaccination. This slide just shows a tweet recently from a very prominent public health author, Laurie Garrett, who's written some great books on public health and infectious diseases. And it just highlights the amazing use of tools like Twitter and other social media to get information out there, for example, about the Omicron variant, the wonderful way in which labs in South Africa were able to let everybody know around the globe within hours, and instantly we're able to share this data. The sequence was shared, and labs all around the world and public health authorities around the world were alerted. This is remarkable, the pace at which this is able to be done, the scale at which it's been able to be done. And here's some work from Professor O and a group of colleagues around the globe, and it was a privilege to take part in this study, which drew on our world in data as well as Google global mobility data to try and understand the association between COVID-19 spread and mobility restrictions in 36 countries, and really found some really interesting information about the pace at which shutdowns occurred, which mobility was restricted. Going hard and going early has made a big difference. When you shut people's mobility down, it really nipped transmission in the bud very early. And then modelling has been used extensively in my country and many other countries to inform pandemic planning and decision making. And our government in New Zealand has drawn on modellers from backgrounds in physics and mathematics and computer science, not the traditional epidemiologists, to be able to anticipate when to undertake lockdowns, when to let people go from lockdowns, when to, how long to persist with managed isolation and quarantine, how long we should look for before vaccination levels get to a certain level before we can start to increase freedoms of movement and open up shops, schools, and all these things have been heavily informed in my country and many others by predictive modelling tools that depend on data, evidence, but also high-powered computer simulations that until recently could not have been done. And then coming back to the public communications, these cartoons look very simple, but behind them is a sort of deep, sophisticated science. And they've been able to get out there using social media platforms to make complex information intelligible to the wider public about public health measures and about the epidemiology and the need to take these measures in order to shift the curve, if you like. So I think that COVID-19 and other tools that we've been developing in the last decade or so have really accelerated the progress and expanded our view of the possibilities of digital public health. Particularly with COVID-19, there's been unprecedented data surveillance capability that's developed. And we've been able to use massive amounts of information in near real time, which enables artificial intelligence and predictive modeling to inform our public health responses. And we've also been able to see the ability to reach and access people with evidence-based public health interventions at incredible pace and amazing reach to lead to population health impact that hasn't been possible before. However, let me just go through very quickly a number of cautions. The first is emphasis. Most digital health strategies emphasize greater personal responsibility for health, but being public health people, of course, we want to be careful that this doesn't draw attention away from the importance of tackling social and economic determinants of health. So we need to work at both, giving people the tools for behavior change, but also making sure that our policymakers reset the determinants, the social policy, the housing policy, the economic policy, the employment policy, the income policy that we know has such a huge impact on people, and providing welfare support at the same time as giving people personal tools. So that's up to us as advocates for public health to not let them forget that. The other one is ethics. Who owns my data? Who gets to use my data? Is it my employer? my insurance company, the government? Who has sovereignty over our data? There's a natural resistance by governments once they have our data to want to hold on to it, to suppress it from release. But actually, I think as a citizen, I have every right to want access to my own data. So I think these debates and conversations are really important and need to continue, and particularly at this moment when governments are being quite heavy-handed with their actions, rightly so. And then equity. What about health and digital access and digital literacy in disadvantaged population groups? We shouldn't assume that people have access to these digital tools. We shouldn't assume they know how to use them. We shouldn't assume they know a lot about health literacy or digital literacy. We need to pick up on that phrase that was used by HIV colleagues, nothing about me without me, when we think about digital health. There's a lot of hype about the potential of digital health, and I think that can outstrip the reality about what is effective and equitable. The data that we collect in online surveys, for example, may not be truly representative of the entire population. What about the people who don't have online access and can't take part in these surveys? So we need to better understand the biases in data collection that exist through social media platforms and other tools that we use and draw on, and try and balance the hype and the opportunity with a bit more realism and using our epidemiological savvy to temper and to be a bit more cautious. And I think there's no space where this is more evident around evidence or the lack thereof than in the app space. And if you go onto the app stores, whether it's the Apple store or the Android store, you will find thousands, if not millions, of health-related apps, but the vast majority have no background in theory or evidence to inform their development. And I believe this is something that we need to be really good at doing in public health, is promoting the use of evidence. A colleague of mine, who it's a privilege to know, Dr. Eric Topol from the Scripps Translational Science Institute in La Jolla, San Diego, has written a number of books about health and IT. And his latest book is called Deep Medicine. And he looks at this as a clinician and sees the opportunities for AI creating space for rebuilding genuine physician-patient relationships. And he says, if we allow it to, it can recreate the space for caring, trust, and empathy. And then he says this: we need to rapidly embrace the future the right way so we can go back to a simpler past. And I wonder if we take that phrase and apply it to digital public health as opposed to personal health, how do we embrace the future the right way? I believe looking at the Ottawa Charter can give us some clues. So I think we need to continue to enable, mediate, and advocate, but we might need to use digital tools. We need to expand our views of what environments and settings now include. So when we talk about creating supportive environments, that should include the virtual space, the digital space, where many people spend large amounts of their lives. We need to think about how we transform and scale up interventions that build personal skills, that enable community action, and can shift health services and reorientate health services in a way that's both ethical and equitable. How can we do that digitally? We've learned a lot in the last 2 years about doing that in various ways. How can we enable healthy public policy that includes healthy digital policy? I'll come to that in a minute. And better and more evidence is urgently needed to inform all of these strategies for Ottawa Charter 4.0. And just shifting geographically from Ottawa to Montreal, there was a Montreal Declaration several years ago, 2018, for responsible artificial intelligence. And if you look at the principles there, they talk about well-being, respect for autonomy, protection of privacy and intimacy, solidarity, democracy, equity, diversity, caution, responsibility, and sustainable development. Now, all of those words and terms are familiar to us in public health. They absolutely are the core values that we hold to as public health people. So here we are, here's a ground-swelling group of people who got together 3 years ago to come up with some guidance for around how we should behave with artificial intelligence, but they're really using public health values at the core of this. And I think that's a wonderful thing to see. And then even the United Nations has declared on its 75th anniversary that they want to improve digital cooperation as a key part of the role for the United Nations and is underpinning the Sustainable Development Goals, the 2030 Agenda. And they say these words: we will improve digital cooperation. Digital technologies have profoundly transformed society. We would agree with that. They offer unprecedented opportunities and challenges. Yes, we can agree with that. And then this final piece: digital technologies have potential to accelerate the realization of the 2030 Agenda. We must ensure safe and affordable digital access for all. And I think we could all support that statement. So I'm going to end at that point and hope that that's been both stimulating and informative. I'm sure many of you have got lots of insights and maybe some questions and challenges. Thank you very much for being listening, and I look forward to the ongoing conversation. Thank you.
Thank you so much, Professor Bulan. It's so comprehensive and then wide aspect of digital options, and also wide aspect of cautions and then contribution from the digital. So that it seems to be really nice to be added after Ottawa Charter. So thank you again. And now we are going to open the Q&A session from the audiences. Then if you have question, then probably we can have a 14-minute Q&A session. So probably about 5 to 6 questions. When you have a question, please turn on your camera and then speak to the Professor Bulan directly with your microphone.
Stunned silence.
Yep, the Koreans are a little bit shy person at the initial phase, but not.
Maybe we could put things into the chat. Oh, here we go. Here's someone.
Yep. The Professor Mang mentioned that I'm a professor.
Yeah.
Professor Mang, could you directly say something to the audience and the Professor Bulan after having your own microphone?
I'm sorry, I'm in a bit noisy place.
It's quite, yeah, it's totally fine, I think.
I think was your question around the use of telemedicine and the reluctance of some of our clinical colleagues, is that right?
Well, I'm a professor emeritus at Preventive Medicine and Public Health at the Catholic University College of Medicine here in Seoul. I first of all would like to thank and congratulate you for your wonderful talk today. I am particularly happy to meet you this time because I have also been involved in anti-smoking activities in Korea for more than 30 years. I, in fact, created the Korean Society for Research on Nicotine and Tobacco in 2008. Now I have one question to you. Telemedicine is a hot issue in Korea these days, and the Korean medical community generally opposed to telemedicine, which has very much to do with the use of digital and mobile technologies, I think. What kind of advices would you give us on this?
Well, I think that what we've seen here in New Zealand with a couple of lockdowns has been that clinicians have been reluctant to move across to telemedicine and didn't think that this would be a good thing to do. But actually, we've found in some surveys that patients quite like it. And I think what we'll find is that patients will drive the demand and that clinicians will have to catch up. Now, I don't think everything's going to move across to telemedicine format. And there are some things where it's not clinically safe. But I think there are many opportunities to reduce inconvenience for many patients of having to come in public transport or drive a vehicle through heavy traffic, try and find a car park, find their way through a busy hospital, wait in a waiting room for an hour and see a clinician for 15 minutes, when instead of doing that, you could do that from the comfort of your own home for many, many clinical encounters. And so I think, consumers of healthcare will probably drive the demand for telemedicine. And I've seen this, I think COVID-19 in many countries has disrupted our current old models and will drive a leap in change in this area of telemedicine. And it has demonstrated that it's entirely safe and possible to see many patients, particularly people with chronic care management, where they can wear wearables and remote monitors, have their blood pressure measured. The laboratory results can be, collected and available to the clinician in the clinic setting, and they don't have to be physically present to have a perfectly safe consultation. So I think, it's selected, it's not universal, but I think it's entirely safe and appropriate in many, many situations. And we can save patient inconvenience, patient cost, and health system cost and inconvenience. In fact, we could probably increase the number of patients that a clinician sees using telemedicine tools, again, in selected circumstances. So I think the challenge will be to work out exactly what those kind of conditions are and how we can do that safely and ethically without sacrificing clinical care. And I think one of the take-home messages from the data that I've seen on surveys that have looked at this is that an initial face-to-face encounter is extremely helpful in building the relationship and rapport between the patient and the clinician. But thereafter, the digital encounter is just as effective and often more welcome by patients than having to come back and see the doctor. So it's that initial meeting, and then so a hybrid model, I think, is probably the way we're going to see it play out more and more. But I was doing, digital communications when I was working in Papua New Guinea for almost a decade, using radio telephone and diagnosing people with malaria and tuberculosis without seeing them, sometimes using nurses just based on symptoms. So this is nothing new. People working in remote isolated settings have been doing it. It's just that we've had the luxury in many, many countries of having the patient right in front of us. And I can see a time when we will do some of this with virtual headsets or holographic patients, and with gloves that enable tactile capability to be able to actually, potentially palpate someone's abdomen, or even, I know this sounds crazy and futuristic like science fiction, but in the lab, these things are actually possible now. So I don't think that with the quantum computing tools that are coming on stream, I don't think some of these things are far from reality. And we just need to look at the gaming world and see where it's going, and imagine that the future of healthcare is going to look very, very different. And not just the sort of simple telemedicine where it's faces on a screen, but these ancillary tools that make the whole clinical encounter almost replicate the real thing.
Thank you.
Great question.
Thank you so much. Another question from other audiences. Please turn on your camera and speak with your microphone. Anybody else?
By the way, I haven't mentioned the issue of, people spending too much time on screens and gaming addiction and all of those kind of downsides of technology. But I'm well aware that there are problems when people occupy the digital space too long. I mean, I'm tired of doing it myself. I'm sure you will feel like at the end of a long day on Zoom, it's exhausting. And so, we have to be conscious about weighing up and getting the balance right when we talk about digital health in some of these situations that we're envisaging for the future.
Yeah.
If there is
already know. Yep,
if
go ahead.
Questions, may I have a chance to talk?
Yeah, sure.
So First of all, I'd like to thank you greatly about your lecture. So I think that this is really timely talk about the digital health, because still there is very much controversy about the use of the digital health in the medical service now. So as Professor Wang said, the Society of Medicine in general is opposed to the use of digital health in the service. But it's changing now. I think that it's changing now because of the COVID-19 and because of the people's attitude about the digital health, because the people want safety in their service. So that is the most important, I think, criteria when we think about the digital health in the service. So if we really want to ensure the safety in the service, I think we need to incorporate the digital health in the service. As you said, the hybrid model probably the best way to go, because we should keep the offline meeting with the patients. That is also essential part of medical service. But for safety reasons, sometimes you need to take the healthcare service in our practice. So, so that is the way to go. But still, there is a challenging and the obstacles about the realization of digital health. So I think that we need to cooperate all the experts in the medical society, I mean international society. But still, I don't see the clear movement or vision of such an international core about the digital health incorporation. So I see this seminar is one of the purpose, but what do you think would be the best way to realize the digital health in the health community? Not just one country, an international community. So what's your vision and thoughts?
That's fine. Look, I finished with a couple of slides which referred to what the United Nations is doing around global cooperation on digital tools generally, not just digital health. But I also mentioned a number of agreements or principles of guidance that's been set up from various groups like the Montreal Agreement. And then the WHO is obviously developing strategies around digital health. So I think we do have global bodies that are taking a keen interest. I mean, there's a lot going on around the social media platforms like Facebook and you know, these very powerful platforms which have potentially opportunities for benefit, but also for a lot of harm, such as spreading conspiracy theories and misinformation and so forth. So I think, you know, there's going to be an ongoing conversation that needs to take place with these global bodies, trying to set some standards and benchmarks to try and make sure that we get a balance. It's a bit like a Pandora's box. You know, you open the box a little bit and all this stuff comes out, which is very exciting, but potentially has a lot of downsides. And so I think these global bodies need to be working very, very rapidly, and they have to work with companies that reach out to such a large proportion of the world's population in order to harness their power and temper, control their algorithms so that they're not harm producing, but they are only beneficial. Now that is very ambitious, but you know, in the US, we've got the CEO of Facebook appearing before a Senate committee, and they're talking about splitting up some of these companies because they're too powerful. They reach out to too many people in the world, and so they have this immense power. And I think these kind of global, it's kind of like a non-proliferation treaty or a disarmament treaty is probably where we're going to have to land up in a sense to try and get some sort of global agreement for what the rules are. The problem is the technology's outstripping our ability to catch up with it. And I think that's very difficult for governments, which tend to move slowly. They're caught up with political cycles and political processes, which tend not to be very nimble. Whereas the commercial world is all about going fast and trying to win the space to be ahead of the competition. And they are writing the rules as they go, but they're not taking everybody with them. So I think it's for voices of groups like the public health community who have to speak up on behalf of the public around, equity and the social determinants of health, the importance of health equity, the importance of fundamental ethical principles about first doing no harm, about preserving autonomy and control over your own data. These are sort of things which we as public health people have a right to speak into. And I think we need to make our voices heard through whatever channels we can do, whether they're global networks or even at our local level, and grouping up with other societies and like-minded groups. And, we can shift the curve as we've done with COVID. We can try and bend the curve down on some of these processes that seem to be on an inexorable upward trajectory if there's a weight of public opinion. We've seen this happen before, global power, and it's much more possible, ironically, using these kind of cooperative, collaborative tools that are now at our disposal.
Thank you.
It's not easy, but I think these are kind of where the answers lie.
Thank you so much. The 1 hour is so short to discuss these interesting issues. So that already we had a 1 hour discussion. So that probably we need to go to wrap up. So that let me invite one of the most distinguished senior in Korean society, Professor Emeritus Professor Kwang-ho Mang, to give us a short concluding remark for this global scholar distinguished as a first session. Professor Mang.
아유, 수고 많았습니다. 아주 좋은 구상을 하셨는데, 이렇게 이슈화되어 있는 문제들을 아주 최근 그런 지식과 정보를 서로 공유하고, 무엇보다도 회원들 간에 서로 얼굴 잘 못 보고 지내니까 이런 방법으로, 이게 오프라인에서 있으면 제가 갈 수 있겠어요? 못 가지. 네, 온라인이니까 이렇게 되네요. 우리 홍희철 교수 다음번 이사장이신 것 같은데 큰 중책을 맡으셔서 축하와 또 기대 말씀을 드립니다. 오늘 멋진 사회를 보여주셨습니다. 고맙습니다. 네.
네, 고맙습니다.